So we're going to move on to some of the substance matters or subject matters, including, for example, musculoskeletal injury in the context of minor injuries. Now, with minor injuries, almost all minor injury departments are equipped with X-ray service provision, and but not not every MSK injury requires an X-ray diagnosis. And therefore, that's why we've kind of made this quite broader on X-rays and also beyond, like fractures and beyond, for instance. Very briefly, though, in terms of the actual skeletal system, the skeletal system is formed of bones, cartilage, and these are connected by ligaments and tendons to form a framework. And of course, bones are the most solid part of our bodies. They ensure they provide structure to our body, and they contain a number of different functions which are very important. So they give structure, they define our shape, they help us with movement down to the various different joints that we have, and also the muscles that help to pull and kind of move our various different muscles. They also protect. They protect solid organs, including the brain, the lungs, and the heart. So in the example of the rib cage or even the skull. They also help with mineral homeostasis. So they store calcium, they store phosphate, they store magnesium, all of which are readily activated and released by the action of hormones like parathyroid hormone and even vitamin D. Bone marrow in of itself, which is kind of just here in the marrow cavity, can help with the hemopoiesis, so the formation of blood cells, which is why many hematological cancers initially take place and take root rather within the actual bone itself. So bone is incredibly important, and provides a lot of, for example, a lot of so I'll just admit. There yeah, so bone itself is very good, very important, and therefore problems with bones can cause significant issues. And this is where we want to focus this particular segment of the masterclass on. So has anybody ever diagnosed somebody with a ligament rupture or ligament rupture? Or referred somebody on the suspicion of a ligamentous injury? Could be to physio, could be to orthopedics, could be go to A&E. Yes, loads, absolutely. Now, ligaments are very important. And when we talk about sprains, we talk about ligamental injuries. When we talk about fractures, we talk about bone injuries. But sprains are normally down to ligamental problems. Now, clinically speaking, a ligamental tear would be very painful, and you would get significant laxity of the joint. So, for example, somebody with an anterior cruciate ligament tear, whilst they're playing football, for example, they won't be able to walk. And when you examine the joint, there'll be a lot of movement of that particular joint because ligaments hold bone to bone, of course. And one of the key skills in minor injuries is differentiating a sprain from a fracture. Now, an X-ray won't be able to do that for you in the majority of cases. It will be able to tell you whether there's a broken bone. There can be some secondary signs that may suggest there might be a ligamentous issue, which we'll talk about later. But generally speaking, an X-ray may not be. Now, the point of mentioning this is that most minor injury units are also linked to outpatient musculoskeletal services. So, for example, what happens is that when somebody has had an acute injury, let's say a knee injury whilst playing football or rugby, at the time of the injury, they may be in a lot of pain. The X-ray may be normal, and they may have a little bit of movement in their leg, but not to the same extent. But they can still weight bear and they don't necessarily need admission to hospital. In which case, you need to be in the position where you understand your local protocol, and these patients are often requested to return with an outpatient musculoskeletal service, often run by emergency care clinicians, including ACPs, ENPs, and A&E doctors. But sometimes in some areas it may be run by orthopedics. All depends on what your setup is really. So know your local guidance and local referral kind of criteria. Of course, with ligaments, you have your tendons. Interesting piece of trivia, answer if you wish. Does anybody know the muscle in your body that you can work out in theory 24 hours a day? So there's a muscle in your body that is designed to work 24 hours in a day. Not your heart, obviously. I mean, somebody might say the heart, but it's actually like a peripheral muscle. Does anybody fancy a guess? Nobody? It's your calf muscle. Um, Lumbar. Well, not necessarily because you can't stand up all day. You will get tired, but it's actually your calf muscle. Because actually, when you're sat down, so when you're sat down and your feet are on the ground, your calf muscle is still contracting slightly. And of course, when you're stood up and you're walking, your calf muscle is contracting. And even when you're, for example, laid down in bed and you're sleeping, for instance, your legs bent, you're moving your ankles without realizing, but that's your some of your muscles, including your calf, is what's holding all of this in place in tension. So your calf muscle, you can technically work out 24 hours a day. It's what an orthopedic surgeon once said to me. So I thought I'd pass on that knowledge. You can work out whether it's useful knowledge or not, but might be useful in a pub quiz. But tendons fundamentally are fibrous connective tissue that attach muscle to bone. Tendons may also attach muscles to structures like the eyeball, and they help to move the bone or structure. Now, musculo-tendon junctions are ultimately where the tendon attaches to your muscle, and this is the most frequent site of injury. There's also osteotendinous junctions where tendons attach to the bone. So you've got the MTJ, which is where the muscle attaches to the tendon, and the OTJ, where the tendon attaches to the bone. And they're also points of injury, but mainly it's the musculo-tendon junction, and we're going to look at some of these injuries. So we've spoken about tendons, we've spoken about ligaments, and of course we have to talk about cartilage, because cartilage is not just present within the MSK system, but is also present in areas like the ear, the nose, and also in the throat by way of the vocal cords, for example. It's a non-vascular type of connective tissue. Now, the non-vascular type is very important because cartilaginous injuries do not heal by themselves. So every injury to a cartilaginous structure requires referral from a minor injury point of view. So if somebody has, for example, they've cut their ear, for example, somebody sliced their ear, or they've fallen down and they've damaged their ear, for instance, that requires a referral. It's a flexible connective tissue and it's avascular. And that's why it will require surgical repair. It's not like, for example, a cut on your arm that will heal by itself. It definitely requires some form of referral. The most widespread type of cartilage is hyaline cartilage, which is, for example, the connection between ribs and the sternum, whilst fibrous cartilage, which is the tougher, more shock-absorbing type of cartilage, is present within the actual or between the actual bone structures. And of course, elastic cartilage is what we've got in our ears and even part of our nose is the springy yellow elastic cartilage, and is also found in the epiglottis, which is where the vocal cords sit. Now, in addition to the tendons and the ligaments and also cartilage, you also have the actual joint surface itself. And this is very important to understand because of conditions like septic arthritis and why they occur. In a minor injury point of view, you can't miss a septic arthritis. But why they occur can be explained by the fact that there is what we call synovial fluid in between the actual articulating surfaces, in between bone one and bone two. So there's significant kind of fluid in the synovial cartilage around this area. Um, and this is prone to infection. Now, why is it prone to infection? It's because it doesn't really have a blood supply. That's why when the synovial fluid starts to run out, you get arthritis as people age. Its synovial fluid is not something that is auto-regenerated. You're stuck with the amount of synovial fluid you're kind of born with. So that's why it's important to maximize the usage of that synovial fluid. Keep moving, keep going, keep walking, and etc. So fracture management. So looking at the list of attendees, of course, with those people who are on the live and those who are going to be watching later, a lot of yourselves work in urgent care centers and also minor injury units, and therefore therefore see fractures and deal with minor injuries. Are there any particular things that you are hoping to gain from this particular section, as we're talking about conditions with regards to managing minor injuries? Anything that you struggle with? Particularly talking about fractures, actually. Let's keep it topic specific. Any challenges that you have concerning fracture management? Yeah, are most complex to manage. Absolutely. Shoulders and knees are most complex to manage, no doubt. So, why don't we talk about fractures first and classification of fractures? So you have a number of different fracture types and they can be classified. The reason why we're talking about classification of fractures is because when you're making a referral, it's very important for the other side to know the type of fracture sustained. It's it's impossible for an orthopedic surgeon or plastic surgeon or an ENP in orthopedics or plastics or to view every single case and take every single history of patients coming through the doors of minor injuries. So it wholly depends on the assessing clinician. So an open fracture is a broken bone protruding through the skin, whilst a closed fracture is a broken bone not puncturing the skin. Um, you also have, for example, stable fractures, which are broken ends of the bone, but they are completely aligned, whilst displaced fractures where the broken ends move out of alignment. So if we're looking at this particular, for instance, diagram or schematic, you've got, for instance, a closed fracture here, which is non-displaced, whilst here you've got a displaced fracture because you can see that the broken bones are not kind of aligned with each other. Now, this degree of displacement needs to be um, um, for example, characterized. So for instance, it could be anterior displacement or posterior displacement, or what we call volar displacement, for example. Or, there could be an angulation of the particular fracture. But we'll talk about some of these terms in terms of classification. Now, warning here, bad picture. As you can see, this is an open fracture where the broken bone is protruding through the skin. And this is the displaced fracture. Now, the first principle of management with regards to minor injuries is that every open fracture requires immediate referral. The reason why I say immediate referral is because um, have yourselves heard of a concept known as virtual trauma or virtual trauma clinic? Often kind of shortened to this VTC. Is that something that's been, is that something that you're aware of? Virtual trauma clinic. Some people are typing. Yeah, virtual fracture clinic. Yeah. Have a lot of remote areas near us, MIU, so they use them a lot. Absolutely. Now, the concept is really good because the idea is based on the fact that many fractures do not need to be dealt with straight away in terms of operations or even decisions. So often what happens is that somebody has a fracture, they're coming through the doors, it's a simple fracture, and we'll talk about what simple fractures look like, and a decision is made by the clinic to refer to the virtual fracture clinic or the virtual trauma clinic. And this is normally manned by orthopedic surgery, and all that is required is the documentation of a thorough history, which we spoke about at the start of the presentation, an X-ray, and for the patient to have a precast film. So they have an X-ray at the time of the presentation. Then they be put into a plaster cast or a plaster of Paris, and then an X-ray post film. And then this is all sent as a referral to orthopedic surgery. Now, the next day they have their trauma meeting and they're all sitting around particular big screens, and they're looking at through the trauma consultant in charge is looking at the various different images and is making a decision, i.e. this fracture can be managed conservatively, so keep in the cast for another four weeks, bring them back to actual clinic, outpatients clinic, where they can get another X-ray, and then we can talk about what happens next. Or it could be, this is a bad injury, and this injury requires referral. Sorry, this injury requires surgery, but we can't do the surgery now because the injury is an ankle injury, and therefore it's very swollen. So there's a risk of compartment syndrome. So they'll tell the schedulers to schedule the patient for a review in about 4 weeks where the swelling can be basically relooked at. So the whole idea is to try and manage a huge caseload of fractures remotely and to make decisions and allow scheduling and follow-up planning to be seamless almost. However, not every area in the country will produce guidelines as to what can be seen in the virtual fracture clinic and what can't be seen in the virtual fracture clinic or virtual trauma clinic, or virtual fracture clinic or virtual trauma clinic. What can be seen and what can't be seen. So ultimately, it's very important to see this. So with regards to open fractures cannot be seen by virtual fracture clinic. And what qualifies an open fracture? If there is a wound and you can see into the wound, that is an open fracture. If, for example, the patient's got a fracture, let's say they've fallen and they've got a distal radius fracture, but there's a graze to the actual wrist, then that's not an open fracture because a graze is not an actual deep wound. But if there's like a hole or like a slit and you can see through the slit and you can see some blood and you can see some muscle or whatever it might be, then that would be an open fracture and that would need immediate referral. And that can't be managed via the virtual trauma clinic. So I hope that's useful information. So as well as kind of open, closed, and displaced elbow and spinal fractures, cervical neck fractures, and compression fracture. So we're not going to be able to go through cervical neck fracture or compression fractures purely because those aren't under the remit of minor illnesses, minor injuries, because they're not minor, because they are central fractures. But we will be going over elbow fractures. So that we've got a particular section on elbow fractures because those are typical fractures. As those are difficult fractures to tell um, on examination and even on X-ray management. But if you haven't signed up through, I'm not sure if you have, but our next masterclass is our MSK masterclass, which is delivered by a physiotherapist that will talk about um, neck cervical fractures as well as kind of lumbar fractures and others and how to manage them basically. So I'd implore all of yourselves to sign up to that masterclass. I think that's going to be we ran that last year and that was a very popular masterclass. And it's the same speaker, so we're very happy to get him back. So transverse fractures are basically horizontal fractures. Linear fractures are, breaking the bone, but it does not move the bone, and ultimately requires conservative management. Oblique fractures are broken bones, are breakages that are kind of diagonal across the bone. So yeah, basically diagonal across the bone. But of course, they can be displaced or they can be undisplaced. So an undisplaced oblique fracture kind of looks like broken ends of the bone, which are completely moved out of alignment. And then you've got, for instance, more complicated fractures that require more complicated management. So, for example, there are segmental fractures. So these are when you have a fracture in more than one place. So the bone is almost split into various different segments. So you've got segment one and you've got segment two, for instance. And then you have a floating segment of bone kind of in between. Here is, for example, you've got a tuft fracture, literally a tuft because it's a part of the bone, for instance. But the tricky thing is that you've got this floating segment. Now, of course, this one, that looks like a bad fracture, this first one. But why is a floating segment very important in an articular fracture like this one? What future problems could it particularly cause? Instability, yeah, it's going to cause fracture instability. It will also cause, for example, joint locking. If there's a floating segment around, and imagine if that fracture is, for example, in the knee, for instance, like an avulsion. So this is an avulsion or tuft fracture, then it will cause mechanical problems later on. So yeah, an avulsed fracture is when there's a broken bone attached to a tendon separating from the rest of the bone. Um, and then it, of course, gets a little bit more complicated in terms of classification. So, we've spoken about, for example, transverse fractures, vertical fractures, segmental fractures, oblique fractures, avulsed fractures.